Hello, and welcome to our Heart Failure Awareness Week Provider Education, Improving Heart Failure Outcomes, a Multidisciplinary Approach. My name is Maghee Disch, and I am the Heart Failure Service Line Specialist here at the Society. Our objectives today are to talk about heart failure disease process and a population review, current trends and needs of the heart failure population, to describe the multidisciplinary team, its role and effects on outcomes, and future recommendations. So what is heart failure? Let's do a quick pathophysiology review. There are many different causes of heart failure. Some of the most common causes might be hypertension, especially uncontrolled hypertension, including pulmonary, myocardial infarction or injury to the heart muscle due to an infarct or blockage of a vessel, valve disease including regurgitation, as well as stenosis, cardiomyopathies including viral, dilated, and hypertrophic, diabetes, congenital heart disease, as well as some other rare disorders such as sarcoidosis or amyloidosis. This slide may look a little busy to you, but I really just want to get the point across about heart failure pathophysiology and activation of the RAS and SNS systems. So whether it's a myocardial injury or some other type of infarct to the heart muscle, you will see an initial fall in left ventricular function and an initial fall in performance, causing myocardial toxicity, peripheral vasoconstriction, and hemodynamic alterations, which lead to remodeling and progressive worsening of LV function. This in turn can lead to heart failure symptoms as well as morbidity and mortality if untreated. The final common pathway is again an injury to the muscle because of either diabetes, a different type of cardiomyopathy, hypertension, or even some manageable or modifiable actions such as smoking or high lipids. Again, this remodeling can be caused by MI. This can lead to hypertrophic rigidity or scarring in the tissue, lead to a diabetic or dilated cardiomyopathy. But in the end, diastolic dysfunction or systolic dysfunction will occur, and it can be both at the same time. And these both lead to overt heart failure. When we look at heart failure, we look at two different types or two different ways to define heart failure. It's either a problem with the filling or it's a problem with the pumping mechanism of the heart. So you'll see on the far left-hand side a normal heart image or normal heart muscle. So this heart would have a normal ejection fraction, normal squeeze, and normal filling. The image in the middle looks at systolic heart failure or a dilated cardiomyopathy. In this image, this pump has been weakened because of the dilation or stretching out of the heart muscle. When this happens, blood backs up and overloads the heart as well as the lungs and other organs in the body, causing that congestion that you may have heard congestive heart failure referred to. And lastly, the image on the far right is looking at diastolic heart failure. You can see the thickened or stiffened heart walls causing a decrease in the ability to fill or relax. So in this image, the heart will not allow enough blood to fill into the heart before it squeezes or pumps good blood and oxygen out into the body and the other organs. So here, the ejection fraction can be normal, the pumping ability is normal, but the filling is not. I really like to use this slide when I'm educating my patients as well as other providers. It's important for heart failure patients to have their ejection fraction evaluated. However, in addition to evaluating ejection fraction, assessment of symptoms through NYHA classification is also important. This is just a slide to remind you about what's a normal ejection fraction, so 50% and above. Below normal would be between 36 and 49%, and then very low would be below 35% mark. As I mentioned, it's very important to use ACC, AHA, heart failure stage, and NYHA functional class to define your patients, not only for yourself to guide care, but also for other providers who may see these patients along the line. I strongly encourage you to ask your providers to use this system if they are not currently using this as a way to define and assess their patients. When we look at heart failure stage, we have A, B, C, and D. A being that the patient is at a high risk for heart failure, but is without structural heart disease or symptoms at this time. B, there is structural heart disease but without symptoms. C, there is structural disease with prior or current symptoms of heart failure. And D are the refractory heart failure patients requiring advanced therapies such as transplant or left ventricular assist device. When speaking about stage cannot change or regress. Once a patient is a stage C patient, they will never go back to being a stage A patient. In contrast, NYHA functional class can change. A patient may come into the hospital in class 4 heart failure and leave the hospital in class 2. Functional class looks at the symptoms or how the patient is actually feeling during activity. So class 1 symptoms is the patient is asymptomatic with any symptom at rest or with activity. Class 2 is symptomatic with moderate exertion, so such as light activity like jogging, going up and down the stairs. Class 3 patients are symptomatic with minimal exertion, so those patients who get short of breath just walking across a room. And then your class 4 patients who are symptomatic at rest. Those patients who walk into the hospital, sit down, and they're tachypnic, they're requiring oxygenation. These are your class 4 and very sick heart failure patients. This slide looks at, again, using the stages and classes to guide heart failure therapy for our patients. This is a very good slide that follows guideline-driven therapy, when it should be initiated, when it should be offered for your patients. Again, a very good slide to take back this information to your providers. So we all know that vicious cycle of the heart failure patient and why we need to break it down. Patients ignore symptoms or are uneducated about their self-management and monitoring at home. They head into the physician office. The office is unable to meet the needs of the patient, or they're already too sick to be treated in an outpatient setting, so they're sent to the ED or they head there immediately. And 90% of all patients that walk through those ED doors with heart failure end up being admitted to an inpatient unit. So this is the only alternative for the patient, and the providers may feel that way as well. Now you have a patient that's in that acute care setting where they're at the highest risk for complication or something bad happening to them aside from their heart failure while they're hospitalized. There are initiatives to reduce length of stay, which can result in poor medical optimization and patients not reaching euvolemia before discharge, again, putting them at a high risk to ignore their symptoms or be readmitted within several days. Just starting the cycle over again, heading right back to that physician office or ED, subsequently being admitted. So how do we break this cycle? How do we break down what the process is for our heart failure patients and improve upon that so that they're leaving the hospital at a lower risk for readmission or complication and even mortality after they walk out of our doors? Readmission relates to disease progression. The more times a patient is admitted into the hospital with acute exacerbations of heart failure, the higher their morbidity and mortality increases. You can see here that over time, the clinical status rapidly declines as the patient is admitted again and again and again into the inpatient unit. So let's look at heart failure in 2014. We continue to watch our numbers rise. The heart failure burden is eminent and ever growing. Heart failure affects nearly 5 million Americans every year, and it's really now about 50% men and 50% women. There are an estimated 500,000 new cases each year, and this is expected to continue to rise to over 750,000 by the year 2040. This is related not only to an aging population, but also for better treatment of heart disease and risk factors and an increased awareness. There are over 1 million heart failure hospitalizations annually, and this has been rising over the past few decades. Heart failure admissions account for over 20% in the people over 65 years and older. Looking at U.S. healthcare delivery issues and how the heart failure burden affects that, we have to continue to look at quality of care, patient satisfaction, and costs of care. When we look at the heart failure population, it's very important that these patients get quality care while they're inside our doors and under the control of our organizations and its providers. However, most recently, looking at optimal care, it's not being reached. Patient satisfaction is very low, especially when addressed with trying to decrease length of stay. Patients feel rushed and pushed out of the hospital. So how do we address and improve that? And of course, the cost of care continues to rise. The heart failure population not being a revenue-producing population and being at risk for high penalties leads us to focus very greatly on our delivery of care for these patients. But in the end, it does seem that our access to care continues to be threatened for these patients, and we are not meeting their needs or meeting our organizational goals as we treat these patients. So your organization's dollars are at risk. We all know that CMS has a focus not only on heart failure, but also AMI, pneumonia, and several other diagnoses and procedures that continue to be added each year. So what do these penalties mean, and who is at risk? These penalties mean that if optimal care and process are not reached, you're going to be at a very high risk for high penalties, decreased revenue through value-based purchasing, and of course, decreased resources for your patients and your staff. Value-based purchasing is here, and it continues to change as it comes down the pike. Currently, the 3 domains for fiscal year 2014 are process of care measures, outcomes domain, and patient experience. The combination of these 3 things will be scrutinized by CMS and by our facilities to continue to improve process and reach optimal care for these patients. CMS hopes through value-based purchasing that we can improve clinical quality, reduce adverse events and improve patient safety, encourage more patient-centric care, of course avoid unnecessary costs or the utilization of unnecessary resources with our delivery of care, and also to stimulate investments in structural components or systems that have been proven effective in improving quality and or efficiency of care. And in the end, to make performance results transparent, comprehensible, and visible for the population, making consumers empowered to make value-based decisions about their health care and really choosing the provider that they want. What is quality to CMS? Again, here you can see a breakdown of the domain weights and the counts for these fiscal years. CMS value-based payments will continue to rise as we move towards the future. So what is needed are technology and analytics that can identify high-yield processes of care that help facilities earn back the money that they're shelling out with their resources, with their populations that they're serving. So the best performers win, but others are only breaking even or even losing. In the future, it looks like we may be moving to episodes of care in fiscal year 2017. So not only will you be responsible for the 30 days after hospitalization as we are now, but you will also be responsible for the 3 days prior to hospitalization and then add another 60 days on there. So you can imagine how difficult this may be to look at episodes of care for a patient such as your heart failure patient with that chronic disease that needs to be treated consistently and continually by a provider who knows the patient, knows the process, and knows the symptoms. So this is just something to think about as you move forward with your organizational structure, process, and improvements. So let's focus on identifying high-risk patients for focused interventions within your organization. We want to focus on process change. The problem is the process, not our providers. Identifying high-risk readmission patients across your systems becomes very crucial. All necessary providers should be involved in a multidisciplinary personalized healthcare plan for each patient. There is by all means the need for standard of practice for high-risk illnesses such as heart failure and AMI to improve patient outcomes and reduce readmission rates, as well as reducing length of stay and 30-day mortality. This must be guideline-driven, evidence-based, and you must continually measure your outcomes and assess where you're making improvements and where further change can be made. When we look at patient-identified factors in the heart failure population, some observed factors would be distressing symptoms, unavoidable progression of disease, psychosocial and environmental factors, self-care and adherence, functional status, and health system factors or access to care. When we review the literature, we see that patients who left AMA, had Medicaid, had a severe loss of function during hospitalization, were positive for drug or alcohol abuse, had renal failure, psychoses, or were the male gender were at a higher risk for mortality and readmission. So what can we do with this information? We also looked at factors precipitating readmission, differing service structures and process, such as a hospitalist or general medicine practitioner versus specialist caring for the patient, the underutilization of multidisciplinary consults, so not calling in the palliative medicine team when they needed to be there, not utilizing your social worker or case manager when you had a difficult discharge or transition plan, as well as utilizing such consults as your electrophysiologist so that you can have that patient assessed for CRT or CRTD, which is a potentially life-saving and life-improving procedure for the heart failure population. Poor symptom management was also associated with high risk for readmission, no involvement of the palliative care team or pain management systems, insufficient advanced care planning or lack of care coordination, discharge disposition. Those patients that actually went home with no home health care or did not go to an extended care facility were at a higher risk for readmission, and insufficient outpatient follow-up, whether that be that patient follow-up isn't planned or that patients do not attend the appointment due to access to care or social factors. So how can we identify these high-risk patients within our organizations? Using risk stratification methods such as assessment versus an automated system, you may be able to work with your IT team to create reporting or identification through your EMR, or you may be able to use just a paper assessment that you can put into your charts that your providers, whether it be physician, nurse practitioner, or staff nurse, can use to risk stratify these patients and identify factors for intervention. Utilizing multidisciplinary rounds, whether it be daily, bi-weekly, or it's an informal, just meeting up at the nurse's station and discussing a patient with the team, versus a formal scheduled multidisciplinary rounds that again happens on a scheduled basis, but involving the entire care team, from bedside nurse to physician and in between. Some systems are using a flagging in their EHR or EMR so that these patients are actually flagged or a different color is shown when they're admitted into the ED or to the unit that says that this patient was actually in the hospital within 30 days. Utilizing consult processes or creating algorithms or flowcharts to trigger consults that are needed for these patients, taking the guesswork out of it for your providers, whether that be social work, case management, pharmacy, palliative care, or the chaplain. All of these consults definitely have an impact on the social risk factors for readmission. The multidisciplinary team can look different at every facility, every organization, but the key point is that it involves the key players that are involved with the patient in their care across the continuum, from outpatient to inpatient to beyond. Pre-hospital, acute care, post-acute care providers, and community involvement are crucial to creating the multidisciplinary team. This again will look different depending on your facility size, your resources, the demographic population that you serve, and what you have available in your community. There is a definite need for a point person to coordinate this collaboration. Use of a nurse navigator, a coordinator, or clinical nurse leader has been proven to be very effective in this role. So the high-risk heart failure patient. To help identify this, you have a heart failure primary team with their interventions, a consult team with their interventions, whether it be surgery, palliative care, social work, etc., and then outpatient interventions. So again, once this patient is identified, all three of these systems work together to identify risk factors, try to alleviate these risk factors or any perceived barriers for the patient or for their family or providers, and work together to collaborate and integrate this care while the patient is in the hospital and throughout the healthcare continuum. Again, consults that you may want to consider for these patients: involvement of that multidisciplinary team, palliative medicine. They can help with symptom management, goals of care, preparedness planning for high-risk surgery such as transplant, left ventricular assist device, or home inotrope. They can assist with scheduling and organizing family meetings and counseling, and of course, end-of-life care. The 2013 ACC-AHH guidelines actually included that acute heart failure multidisciplinary team should include a palliative care team which should be involved when treating patients with advanced heart failure. This involvement can reduce readmissions, reduce lengths of stay, and reduce inpatient mortality. Pharmacy can offer assistance, whether it be financial, educational, or provider assistance. They can decrease medications or the amount of medications that patients are going home on, and really work on cost effectiveness for those patients that may have those social risk factors. Your social worker can help with support, assess the needs of the patient at home, help with home environment and transition plan, make referrals to extended care facilities or post-acute care providers, and of course help involve hospice in either the inpatient hospitalization or helping the patient get home with a hospice care provider. And the chaplain can provide spiritual support and end-of-life care as well. All of these care providers can help you identify the directed interventions available and needed for your heart failure patients. They can help you utilize standard process and practice, putting together algorithms, flow sheets, tools, and assessment for your patient population. And this really needs to begin at the first patient encounter. Take advantage of the captive audience you have. Start this on admission day 1. Start working on assessment, discharge planning, assessing barriers to care, barriers to education, and get the right providers involved. Each heart failure patient really does need a personalized plan of care for transitions, whether that be home health care, extended care facilities, or hospice. Follow-up appointments are also crucial for this patient population. At the very least, these patients should be seen by a provider within 7 days of an acute heart failure hospitalization. Making sure these patients have access to care through transition clinics, home health care visits, or even home provider visits. Make sure that the discharge instructions are clearly communicated and or transmitted to the post-acute care provider or follow-up. Make sure that your organization has a process in place to communicate with these providers once patients leave the hospital, and even after that if they need to contact you for more information or to alarm you if a patient's headed back to your facility. Appropriate referrals need to be made while the patient is hospitalized, including cardiac rehab, physical therapy, occupational therapy, home health, or the extended care facility. Making sure that these patients get appropriate functional assessment and that you're supporting their social needs. One intervention that has been proven to be very successful thus far within heart failure populations is a follow-up phone call within 2 business days of discharge. This is also billable, and this is not an HCAHPS call. With this call, you should be focusing specifically on heart failure symptoms, heart failure self-education and monitoring, and this should really be a healthcare provider that's making this call, making a note in the chart, and if possible, communicating any findings from this phone call to the provider that will first see this patient in follow-up care. Use of a transition clinic has also been proven to be very effective. A heart failure-centered patient care clinic that sees patients after an acute hospitalization or is able to see patients quickly if they feel they may be heading in that direction is a great utilization and way to prevent readmissions. This can be nurse practitioner-led, physician-led, or even call center-led. What we really need to do, though, is make that change while these patients are within our doors, within our arms, and when they are a captive audience. Using the observation units, ED, clinical decision units, and of course the inpatient acute care units to stabilize our patients, optimize our patients, and prepare them for transition back to home or their post-acute care provider, as well as utilizing prevention, self-care in our outpatient clinics for these patients either before or after hospitalization. But making the change while we have them here within our arms is where you're really going to see the impact across the continuum. So how do you get buy-in from your administrators if you need more resources or need more staff? Build relationships, network, and FaceTime. Make your heart failure program and its providers visible to the community, to your other providers within your organization. Show your value, collect data. Make sure to focus on your big ticket metrics such as length of stay, 30-day readmissions, inpatient mortality, and patient satisfaction. By showing that you're affecting these metrics and improving care, you'll get more buy-in from your administrative level and C-suite administrators. The take-home message here is that as the heart failure population continues to grow and become increasingly scrutinized by guidelines and penalties, we must form a standardized approach throughout the healthcare continuum. Involvement of the multidisciplinary team ensures that all aspects of patient care are addressed while the patient is hospitalized, as well as identifying barriers to care. Improving all outcomes and not solely a readmission focus is how you will affect your patient outcomes as an organizational whole. And of course, the number one goal is always improving patient care and outcomes. Thank you very much for joining us today, and I hope that this was helpful. If you have any questions about any of the information that I presented here today or about heart failure multidisciplinary care, please contact me at the Society. Thank you very much, and happy Heart Month.